Hello. Hi. Good afternoon, everyone. Okay, ladies and gentlemen, I'm Dr. Oliver Ong, and we're already going to start our afternoon session. With the first session, we'll have a presentation on the treatment considerations in ASD to be delivered by Dr. Larry Acuña. Dr. Acuña is a regular consultant at the Medical City Pasig and is an active consultant at the Asian Hospital Medical Center in Alabang. Dr. Acuña?
Thank you, Dr. Oliver, for the kind of introduction. Good afternoon, everyone. I'd like to thank the organizing committee and the PSS board for inviting me to speak and also to learn for this event. So my topic today is that treatment consideration in adult spine deformity. Ayaw mag-point. I have nothing to disclose. Next. Ayaw. So my lecture is almost similar to the lecture of Dr. Sembrano. Philippine setting lang naman. Ayun kanina, US setting. We can't do that much.
Yes, magagamit yun.
Okay.
Ano po dito?
Sa harap. Center. Ayan. Ito, dito. Connected. Yeah. Again, my topic for this afternoon is the treatment consideration in adult spine deformity. So I have nothing to disclose. The primary treatment goal in adult spine deformity is to improve health-related quality of life. So most patients will visit our clinic with severe back pain, balance abnormality, and or difficulty in ambulation because of weakness and radicular pains. Let me start with my first difficult adult spine deformity case, which we did with Dr. Chambeng in 2013. Yan, pangit pa ng x-ray. This was a 56-year-old female executive from a prestigious school who complained of severe back pain radiating to both legs and cannot function well. So she had 86 degrees of thoracolumbar curve and 31 degrees of thoracolumbar kyphosis. So this is what we did. We did multi-level PSO to correct the deformity. The estimated blood loss was around 3.5 to 4 liters in a 10-hour operation. No, very challenging. Recovery was very slow, unlike our adolescent cases. She was doing well after 2 months of rehab. And this was her X-ray, post-op X-ray after 1 year. So if you would notice, I don't know if you can notice it. After 3 years, she came back to me and noted a sudden snap in her back just from alighting from a toilet seat. She had severe back pain, and when I did X-ray, it revealed a rod breakage and a fused spine. So for this patient, actually, I did the CT scan after 2 years, and it revealed full fusion. But after 3 years, came back to me with a broken rod. So this patient was very inquisitive. I thought I'll be seeing myself in court. Fortunately, we had a good rapport and accepted very well that this kind of failure can happen. At this time, I would want to share to everyone the learnings on this case. So, factors to consider, we can divide the several factors in according to pre-op, intra-op, or post-op. Adult spine deformity surgery is becoming increasingly prevalent as both life expectancy and functional health expectations of the elderly increases. As a result, there is increasing academic output from adult spine deformity surgeons, which has exponentially risen over the last 10 years. Now, the expanding number of ASD surgeries has created a clinical problem. More surgeries means more failures. So first, let me talk about the cost effectiveness of ASD surgery. Looking at the cost effectiveness of surgeries, McCarthy in 2013 reviewed the cost effectiveness of these ASD surgeries. This is probably the most limiting factor in our setting. ASD spine surgery is much more expensive than adolescent idiopathic scoliosis. Surgeries are longer, spine implants are more expensive. Of course, our industry partners are happier than ever, isn't it? So McCarthy concluded that ASD surgery was cost-effective in improving pain and self-image, but not physical function and mental health. Now, definitely, it has a higher cost. Yeah, this is the quality-adjusted life per year in the 3rd and 5th year of ASD surgery, which is more than above the WHO threshold. So it's really very, very expensive operation. So there is increased complication and failure in adult spine deformity. We expect more postoperative pneumonia, MI, UTI, kidney failure, SMA, occlusion, surgical site infection, and the like, and so on. So complications can be divided into two. Perioperative for less than 3 months and late after 3 months. A range of 35 to 41% in this study. Some would say 60% complication rate. These data should be divulged to our patients so that they would know what to expect in this kind of operations. So as life expectancy is increasing and surgery for patients with ASD is becoming more common, the level of frailty in elderly patients is important to characterize and understanding during their preoperative workup. Now, this study, using the modified frailty index, now it has 11 variables. Looking at the variables, diabetes mellitus, status of independence, history of COPD, pneumonia. This can be elicited during history taking. These variables are very important. The frailty index of 0.09 means one of the variables is present. So as many variables as you have, you increase your incidence of morbidity. Now, there's increasing rate of complications with greater number of frailty variables. Mortality rate is at 10% if you have three frailty variables present. Age and obesity showed to be a dominant predictor of any complication. So another factor, osteoporosis and vitamin D deficiency correlates with screw loosening, non-union, increased rod breakages, and adjacent segment disease. In all patients 65 years old and above, it is recommended to determine the BMD of patients. So experts in different specialties convened and drafted best practice guidelines for assessment and management of osteoporosis in ASD. So their recommendation is to treat patients 2 to 6 months before operation and continue up to 8 months post-operative. But in some situations wherein it's cost limiting, you can use the denosumab or zoledronic acid. And of course, you have to include calcium and vitamin D3 in the regimen. So mental health must also be of concern. This paper published by Diego et al., for which analyzed behavior of 6,000 patients, 20% had mental health disorder. And mental health disorder is a predictor to morbidity. So proper patient counseling and psychological screening and support is recommended. Although it was not fully detailed on what was the primary cause of morbidity in this study, it was told that this group of patients will have higher incidence of readmission and surgery. So another factor to consider is, of course, obesity. Obesity is another concern. So if your BMI is above 30, there's increased longer ICU stay, total hospital stay, longer fusion that you need, prolonged surgery, increased surgical site infection, and prone to venous thromboembolism. Try to avoid surgery in obese patients. So adult spine deformity surgery is related to increased blood loss, longer procedures, which usually requires osteotomy with a longer surgical time. It is advised to prepare blood and blood products such as fresh frozen plasma, use of tranexamic acid, and controlled blood pressure during surgery. So neurologic deficit is also higher in ASD than AIS. So there's a high rate of perioperative neurologic complication in ASD. The International Spine Study Group reported 13.7%, medyo mataas yan, for neurologic complication that can be manifested by radiculopathy, motor deficit, mental status, and sensory changes. So surprisingly, intraoperative monitoring did not significantly affect the result, but you should use IOM. It is related to use of interbody fusion, which has higher ICU stay and increased length of stay. So, may I know who will going to operate on this patient? So after knowing all those factors, looking at this patient, it's a very frail patient. So I don't think there's anybody who will want to operate. In summary, so factors to consider in surgical treatment on ASD is, of course, cost effectiveness, number one. Complications, presence of osteoporosis, obesity, mental health, and the frailty index. And that's the Philippine setting of treatment. Thank you.
Thank you, Dr. Acuña.